there was so much confusion coming from the government and that environment. It basically became an untrustworthy source of information. That idea that we had to be closer to the consumer meant we had to have more frequent interaction with the consumer. You have to have a high tolerance for ambiguity and a passion for complexity. That is the only way to survive in this business.
Peter Fine is the CEO of Banner Health. In this conversation, he explores Banner Health's growth and strategy during his tenure. He also highlights the growing challenge of cost and affordability for the healthcare industry.
So it's become an inflationary environment. It becomes very, very difficult to operate these large health systems, which make very small percentages, 2-3% operating margins.
Peter discusses the challenges Banner Health faced during the pandemic and the development of the WISE Guide, which provided up-to-date COVID-19 information for local Arizona patients.
What the public needs is a source of truth. And the public's not going to trust what's happening at the government level. We got to do something locally.
Peter describes the qualities necessary for the next generation of healthcare leaders.
When all hell's breaking loose, those who stay calm are those that manage it best.
Let's hear Peter Fine's leadership insights from his 22-year tenure as CEO.
Well, good afternoon, Peter, and welcome.
Hi, Gary. How are you?
I'm well, thank you. Let's dig into Banner Health and your leadership. Congratulations on your 22 years as the president and CEO. When you started 22 years ago, did you think you'd be the CEO there for 22 plus years?
I'd never held a job for longer than 7 years, so the answer is no. I didn't think I'd be here that long. But it was a company that was newly formed. It had lots of growth opportunity, had a really, really great board, location that for lifestyle was superb. And it was exciting, quite frankly, to take a newly organized company that came together through a merger of two equally sized systems and try to achieve what the board stated they wanted to try to achieve when they formulated the company. So you get into it, you're excited, things change, you have opportunity, you modify things, you reinvent along the way. And so it was caused us to stay. We became part of the community, part of the fabric of the community. And it was a company that was interesting in what the board originally thought they wanted to try to achieve.
Do you remember the size? What was the revenue when you joined versus what it is now?
Yeah, it was about $1.5 billion when I came. It's just short of 13 billion now. This year we'll be just short of 13 billion, probably 12.7 or something like that, 12.9, and obviously significant amount of growth. An entirely different kind of company today than it was back then.
You were a leader in expanding beyond inpatient care. You mentioned that when you joined, Banner was fundamentally an inpatient care shop. Why did you expand beyond inpatient care? Why did you set the wheels in motion for that strategy, Peter?
Well, when we started doing that a number of years ago, the insurance piece actually came through the inheriting of a Medicare Advantage plan with an acquisition that we did in 2008 of a company called Sun Health, and inherited their 20,000 member Medicare Advantage plan. So it got us into the insurance business from that perspective. 2015, we did another acquisition of the University of Arizona Health Network and inherited a very good sized Medicaid insurance company that now has close to 300,000 members in it. And then a few years ago, now about, I'm going to say 5 to 6 years ago, we developed a partnership with Aetna that we now own 50% of Aetna's commercial insurance business in Arizona. And they run the partnership, of course, but we have 50% ownership of the company. And so and then we expanded into taking at-risk business through taking percent of premium contracts with United and Humana. But in addition to that, as we became more integrated, because we wanted to get first dollar coming in the funnel, and then have people within our sphere of influence through our various services, we recognized that we had to have more services that were consumer oriented, more retail services in which people could stay within our system, didn't have to go outside the system, so that their unified medical record would have all these pieces in it that encompassed these various services. The focus had to be that how do we have more of these services outside the hospital environment to keep people linked into our basically integrated network. And we consistently are looking for more opportunities to create touch points for the consumer and link them into the network that we've created.
You mentioned your board earlier. By expanding beyond inpatient care the way you did, it certainly put some pressure on the board, I would imagine, to understand healthcare more deeply. How did you treat your board? How did you bring the board along in your journey, Peter?
Yeah, I would tell you the board itself, when I came in November of 2000, was one of the strong points and probably the biggest influencing decision factor for me to take the job at the time. And part of the reason for that is they were good listeners, and they had become the board of a new company, not the board of their previous entities. So they weren't constituency based. Over time, there's only one original board member left today. The rest have moved on for various reasons. And we had to explain to them how the company needed to change for a new environment. And so getting into the at-risk business on the insurance side, both in owning and partnering, getting into these various touch points that we have. If you look at our primary markets are in Arizona, where it's probably 92% of our business. 5 other states are more rural markets. But in Arizona, we've got the whole community plotted out, and I could tell you where our next 10 urgent care businesses are going to go, and imaging businesses, because we have them all time and population based. So we look at the population, we do that analysis, we look at the time, we want an urgent care that you can get to in 10 minutes. We want a surgery center that you can get to in 20 minutes. We want an imaging center that you can get to in 15 minutes. So we've got the whole community plotted out on where we are and where we go next, because that idea that we had to be closer to the consumer meant we had to have more frequent interaction with the consumer. And knowing how often somebody might go into a hospital, you had to get into these ambulatory businesses to create a relationship with the consumer.
So the board has worked with you right along to broaden your strategy. And as we mentioned, you've been a leader in that strategy. But the other point of leadership, and you're known around the country for, and that is your focus on an operating model, Peter, which you started basically when you began 22 years ago. Can you share with us your thinking about why you did that and how that's worked out?
Sure. When I first came, literally in the first 6 weeks, I made some pronouncements to the company. And one of those announcements was that we're an operating company, not a holding company, and here's the essence of an operating company. And I started laying out the behavior model and the operating model for an operating company. And the reason we did that is we felt that we could have better control over our costs, and we could move quicker if we were focused as an operating company. It can make decisions easier. And we believed that we could run the company with less confusion. And basically, everybody would know who the decision makers are, how decisions are going to get made. There was no ambiguity, there was no confusion. And that was the approach we decided to take. We still have it today, as big as we are. Can we continue to be an operating company if we were twice our size? I don't know. It gets harder and harder to do it the bigger and bigger that you get.
COVID obviously challenged health systems all over the country. Were there any fundamental changes that Banner adopted because of COVID?
There was so much confusion coming from the government and that environment. It basically became an untrustworthy source of information. So in about the first week of February of 20, I pulled aside Dr. Marjorie Bessel, who was her chief clinical officer, and I said, listen, this is going to get pretty crazy. What the public needs is a source of truth. And the public's not going to trust what's happening at the government level. We got to do something locally. So I pulled her aside and said, you're going to be the face of Banner, and it's probably going to be for 2 years. And she looked at me and said, well, you're the face of Banner. I said, no, I need a clinical face of Banner, and that's you. I think the important lesson that we learned, and Dr. Bessel supported this, is when all hell's breaking loose, those who stay calm are those that manage it best.
Yeah.
Because when you're dealing with, in my mind, in this business generally, but certainly in the COVID environment, you have to have a high tolerance for ambiguity and a passion for complexity. That is the only way to survive in this business.
Yeah.
And if you like complex decision making and you can manage ambiguous environments, and when you look at COVID, it was both of those things. It was highly complex and it was highly ambiguous. And if you can stay calm in an environment like that, you really can manage the process a lot better. We coined that term at the time we put her in that role. We said, we need a wise guide. And, it got interpreted periodically as, what, wise guy? They said, no, wise guide. And the public needed somebody that was trustworthy, that they felt had experience and wisdom, that was gathering information and making the best decision, not from a political perspective, but from what is in the best interest of the public and the best interest of our employees to keep them safe so they could take care of the public. And the goal was to make sure that we came across as a trusted resource.
Yeah. Will the CDC ever reestablish itself, do you think, as the trusted source of information that we all remember that it used to be?
Yeah, you could say that about the FDA also, I guess. I think the only way to do that, you have to critically look at yourself and absolutely look for things that don't work. So in our environment here at Banner, we do a lot of self-analysis of the company. And the whole goal in our minds, what we do can be done better. We just haven't found the way. So we're constantly looking for a way to do it differently. If you get too caught up in the way I'm doing it is the only way that it can be done, well, then you never really change.
Yeah.
You never really look for the better way.
Yeah.
I think the CDC has to become a company that is saying, this didn't work very well. What are the lessons that we learned? And how do we transform ourselves into a company that, or an organization that isn't going to go through this a second time the way it went through this time?
Yeah. Yeah, that's the key. Peter, you talk about testing, and your testing lab conducted a large percentage, 40% of the testing in Arizona. You're very active in vaccinations, providing information. So how do you feel about the role that Banner played that might have been viewed as a traditional public health role some time ago, but public health just simply isn't resourced enough and isn't plugged in enough to do that? How do you view that going forward? I mean, will Banner continue to play this kind of public health role in effect?
I don't think we will to the extent that we did. I mean, we got out of the testing, we got out of the vaccination environment once the states stood it up themselves and created mass vaccination sites. And when there was enough vaccination material that the drugstores could start taking that over, and we removed ourselves because it's not our business. I think there has to be a better line of communication with the public health departments, both at the county level and the state level.
Yep.
We pulled together the chief clinical officers of the major systems in Phoenix and began meeting with the health department, both county and public, on a pretty routine basis through 20 and 21, so that everybody kind of would know what they were doing. We, with the state, pulled together a transfer service that actually Banner helped the state stand it up from a technology perspective, so that as all of these smaller facilities around the state didn't have the capability to handle the volume, they would call into this transfer service who would know where all the available beds were from all the big systems in the hospitals that we had and could allocate those patients so it wasn't overloading everybody. No other state did that until we did it. There may have been some that did it after we did it. We were the first state in the country to pull in that state-operated transfer service, which was a lifesaver at the time that we did it. So nobody got overloaded.
Peter, during the time that you've been the CEO at Banner, we've seen an enormous growth in federal government expenditures in healthcare, and now almost 50% of the population of this country are on either Medicare or Medicaid. How has that affected the Banner strategy? How have you reacted to that over time?
Well, it's problematic because the federal programs of Medicare and Medicaid don't pay our costs. They pay something less than cost. Well, if somebody's paying something less than cost, somebody else has to pay more than cost. And it's a transfer to the insurance world because of the underpayments in the federal world. It's always been there. That's nothing new. It's been there forever. And it's gotten exacerbated, and it's become harder to do because the insured world doesn't want to cover those shortfalls anymore.
Right.
In an inflationary time like that, you see all over the place a lot of companies are increasing their prices. Well, I can't negotiate with the federal government. I'm told what I'm going to get paid. So for almost 50% of my business, pricing isn't a factor. And it's hard to do on the insurance side when you have multi-year contracts. So it's become in an inflationary environment, it becomes very, very difficult to operate these large health systems, which make very small percentages, 2-3% operating margins, not even enough to reinvest in serving the public out into the long-term future. So it's a very tough business to operate right now because of that.
Yeah, I mean, the operating margin issue is a big issue, and you talked about making enough at the operating level to sustain capital expenditures, but how do you think about even the rest of this decade? Are operating margins going to continue to shrink as they have in the past? They must have taken a huge hit during your COVID days. So how do you see this working out over the next 5+ years?
Yeah, they will take huge hits. They did in COVID. Obviously, we got government money to help supplement those negative operating margins or barely positive operating margins. And now that we don't have government money to cover that, you're really seeing systems all over the country having significant losses that have been reported all through this year. And some that were making a lot of money in the past are making half their operating margins.
Yeah.
I don't see that pressure stopping because the wage pressure has gotten extraordinary. And so there's, I think, going to be a very difficult process in trying to staff many of these healthcare environments, primarily because of the labor issue, which I think is going to put huge pressure on organizations that really can't make that up through a pricing structure.
One of the reactions to those pressures that you're referring to is consolidation. What's the Banner thinking about consolidation, both vertically and horizontally?
Right. Well, certainly, if you look at the history more recently, that's been heating up. and I think it's going to continue to heat up. I think the pressures are clearly going to force more organizations to come together from a scale perspective. The question is, how's the federal government going to respond to that? Clearly, their traditional response around overlapping geography, it was pretty well known. But now this looking at things that have no overlapping geography, now it's a little bit curious. What does that mean for organizations coming together, and what does that mean as it pertains to how the FTC will respond to that? But clearly, I see no pathway other than organizations becoming much bigger in scale because of the cost structures that exist right now, and the need to look for opportunities to affect their cost and grow their business.
Well, speaking of M&A, what you're thinking about the large companies, the CVS, the Walgreens, now Amazon, Optum, elbowing their way into the ambulatory primary care world, how's that going to affect Banner and other health systems?
You see the more strategic decision making around the big players of Optum and CVS and so forth that are trying to reinvent their models. Why? Because healthcare is where the money is. Yep. It's a gigantic business.
Yep.
With so many players drinking at the trough. There's opportunity either by reinventing the business, which sorely needs to be reinvented, or looking for opportunities to identify revenue sources by doing it. So it's going to take some very adept systems to think through how they respond and how they relate in some cases to organizations like that.
Well, what's the asset that the large health systems have compared to some of these larger, well-financed organizations?
Well, we have the business that they don't want to have. We have the expensive acute care businesses. They're still going to be needed. I go back to 1984 or something like that when DRGs came out and everybody said half the hospitals would be closed in 10 years. Well, that never happened, and all you had to do is look at the demographics to understand why that wouldn't happen. And so certainly for the next 25 years, we're going to have this huge bolus of people going into an age category where they're going to need a lot of resources. And hospitals are going to have to be there to take care of the sickest of the sick. So we have a business that they don't want to have because it's a low margin business for the most part. And they want to strip off the high margin businesses associated with that. And so we've moved into population health because we see the expertise we've built that we can actually manage populations and do it at a profitable way.
I've got one other question, Peter, if I could ask you, and that is for the younger up and coming leaders in healthcare, what advice do you have for them?
I would say a couple of things. One, the healthcare arena has so many pathways in it today, more than when I came out in the middle 70s. There are many different pathways in which you can be in the healthcare environment that didn't exist, 40 years ago. So when I was going to school, and so you need to be highly flexible in your thought process of where you fit and where you want to fit within the healthcare industry. Second, you need to create a capability with skills. You have to understand the skills that are needed today, which are way different than the skills that I needed in the mid-70s. The skills are different today, and you need to make sure that you're enhancing your skill set so you become much more attractive to these new opportunities that exist out there. And the last thing I would say, you better understand how people think. If you really don't understand people, because everybody wants to think this is a tech business, but at its core, it's a people business.
Yep, for sure.
And you got to understand people and how they think, how they relate, how they want to use technology, where technology can and appropriately be used. But if you've grown up in the tech environment too much, you sometimes lose sight of the fact that it's really a people business, and you have to be able to understand people.
That's great advice, Peter. Thank you, sir, for your time. This has, again, been a terrific interview.
Happy to do it, Gary. Thank you. Bye.
Bye.